to take a moment to recognize all 51 students that are connected to this live class that we are doing on Zoom and also doing on YouTube. The reason we're doing it on YouTube is so that you guys can go back and review, go back and study anytime you want to. It's like having the instructor inside your house. Now listen, don't tell people I've been to your house. I will get fired. So don't do don't do that. Tell them I was watching, you was watching the video. All right, so chapter 7. Let's go to page 175 in your nursing assistant book. And when we finish with chapter 7, you guys can ask me questions, okay? All right. Now, chapter 7 is talking about basic nursing skills. Basic nursing skills, okay? Now, as nursing assistants, you will be doing more than ADL care, okay? You will be doing more than dressing, washing the patient, elimination, and stuff like that. The nursing assistant is chosen for a great work. The nursing assistant has a great deal of responsibility. And it's important to know your role. It's important to know what your job is. And if you know what your job is, then you will do it right. And you will get promoted, you will make more money, you will go to college, get your degree, and keep moving up, okay? So we're gonna talk about basic nursing skills. So basically, these are things that a nurse would do, okay? But a nursing assistant can also do it as well, all right? So let's talk about the first skill, the first thing here, page 175. Explain admission, transfer, and discharge of a resident. So yes, we do more than ADL care. And when the patient comes to us, the patient coming to the facility where you work or coming to the hospital, we call that admission. Admission is the new patient coming in. What brings them in? Well, illness, disability, loss of mobility, okay? So your patient would lose freedom, would lose their health, and they end up going into a nursing home. But the problem is that people don't really like going into the nursing home, okay? Sometimes they don't know that we are there to take care of them, and some of them would say, I would rather die than go to a nursing home. Because they see stories of people in the nursing home that are abused, mistreated by nurses, by CNAs, by caretakers, by caregivers. So we have to realize that what we're doing is very important, is sacred job, okay? So admission is the new patient coming in, okay? It's the new patient coming in into the facility. So the patient is afraid. The patient has anxiety. The patient has stress. The patient is unhappy. They don't want to be there. Okay? So what is our job? What can we do? Page 175, let's look at the guideline. The guideline says, prepare the room before the patient arrives. This helps the patient feel expected and welcome. Right? So that helps the patient feel more in their skin, more at ease. If you restock their supplies that they may need, right? That makes the patient feel good. Oftentimes they would have an admission kit that you would get for the patient. The admission kit could have personal care items, bathing items, basin, emesis basin, pitcher, water pitcher, cups, toothbrush, toothpaste, etc. So is it male or female? We need to know that too. So the CNA needs to go to the nurse and ask for report. They're not necessarily going to volunteer report, but you need to ask for report. You need to ask is my patient male or female, right? Because that makes a difference between a bedpan and a urinal, right? Between getting pads for a young female and not getting pad because that's a male or that's an older female that already been through menopause. Okay, we need to know if the patient is continent or incontinent. Continent means they're able to hold their bowel and bladder. Incontinent means they can't hold it, so they go on themselves. So we need to know so that way we can get briefs. We need to know what size the patient is. Why? Because there's a difference between small, medium, large, and extra large brief, right? We need to know if the patient is independent. Independent is the person who can do things for themselves. And all we do is watch and we observe and report. We give direction, we supervise. We need to know if this patient is dependent, meaning that we do everything for them. They depend on you. They depend on staff. We also need to know if this patient is assist, meaning they are weak but they want to help, they want to do for themselves. All we need to do is give some support, right? So when a new patient, page 175, when a new patient arrives at the facility, note the time and her condition. Okay, if patient is using wheelchair, stretcher, or is walking, who is with the patient. The third bullet point says, introduce yourself, state your position, smile, be friendly. Always call the person by their formal name until they tell you, you can call me by my first name or whatever. So that's very important to know that. Page 176. Never rush the process of admission, okay? Don't do it so quickly that you want to get rid of the person, okay? Explain the day-to-day activities, the day-to-day life of the facility, okay? So you would explain to the patient at what time breakfast comes up, etc. At what time breakfast, lunch, dinner, supper, snack, okay, where the shower room is, how the call light work, etc. So the patient needs some information. The patient needs detail, and that's what you are going to do. You're going to provide some information that's going to help your resident feel at ease, feel at peace, right? Handle personal items with care and with respect, okay? Admission is a stressful time. So observe the resident and report to the nurse. Observe if there's something missing, if there's a problem, right? For example, if you observe a tube that was disconnected, like an IV, so you got to report to the nurse that this patient has an IV site on the left arm, on the left forearm. All right. If the patient seems confused, combative, unaware of their surrounding, patient has difficulty breathing, patient has pain, sign of distress, bruises, wounds, that's the big one. We need to look at the skin because the patient may be in the hospital for a very long time, right? The patient may be in the hospital for a very long time, and guess what happened? Well, they don't get turned as often as they should. And now we have the patient comes to us to the nursing home with a big wound. So that is something that we need to be aware of, okay? And pass that information on to the nurse. So page 176 at the bottom, admitting a resident, identify your beginning procedure steps. Never ever forget your procedure steps, okay? Admission for any skill, okay? Identify yourself, wash your hands, identify the resident, explain the process, the procedure, provide for privacy. All right. 5, you now part of the admission, We measure height and weight. We measure vital signs, blood pressure, temperature, pulse, respiration. We measure, you may have to obtain urine specimen. We do a good inspection of the skin of the body to report any abnormality, right? Complete some paperwork, obtain urine or stool specimen, right? Help the person put personal items away, provide fresh water, right? Show the room and bathroom, how things work with the bed control, right? And with the call light. And then number 7, page 177, introduce the resident to his roommate if there's one. Make sure resident is comfortable and make sure provide privacy. Place the call light within reach. Then basically you do your finishing steps. So admitting a resident is something that you need to know because the job is going to require that you know what you need to do for the resident: height, weight, vital signs, urine specimen, complete paperwork like an inventory list, right, etc., right? Transfer is basically a patient going to another area of the facility. It could be another room, it could be another floor, okay? They may be in a in a Alzheimer's unit, and then something happened, patient fell, broke a hip, and now they need to, after surgery, they need to be, or if there's, that sometimes there's surgery, sometimes not, but the patient needs to be watched on a subacute unit. So what does the CNA do? Transferring a resident, okay, page 178, identify yourself, identify the resident, wash your hand, explain procedure, collect the items to be moved into the cart. What items? Well, whatever the patient came in with. Okay? Page 178. Okay? Page 178. All right? So, basically, help the resident help the resident into the wheelchair, right? Introduce the new resident to staff, introduce new resident and staff, right? Number 7, help the resident put personal item away and then continue with the finishing steps. All right. So the CNA needs to know how to do the admission, needs to know how to do the transfer. The discharge basically means that this new patient is going home. Okay, patient was doing bad, we fixed them, now they get to go home. So one question that if you find later you need to know how to answer is that nursing home patients, sometimes they do go home. When they get better, they go home. Discharge is the patient going home. All right, page 179. What do we do when we're discharging a patient? Okay, step 1, 2, 3, 4. That's your beginning procedure steps. Okay, step 1, 2, 3, 4. That's your beginning procedure steps. Number 5, vital sign. Compare inventory list to the items. So what is the inventory list? The inventory list is basically a list of everything that the patient came in with. Okay, patient came in with a bag that has 2 shirts, that has this, that has that. Well, you just make sure you compare the inventory list from admission to the inventory list of discharge. Where are we? Page 179. Compare inventory list, put personal items to be taken away. To be taken away by the resident, help resident get dressed and transfer onto the wheelchair. So we're basically doing our ADL care, right? Stay with the resident, help the resident say goodbye to other staff, take resident to area for pickup, wash your hands. Okay, notice who's picking up the resident, who the resident is living with, because you will have to report that information to the nurse, right? You'll have to report that. All right, number 12, document the procedure, document vital signs, right? Document time of discharge, mode of transport, who was with the resident, what item the resident took with her, etc. Okay? So, on your resume, you can write a lot of things down. Skills that you have. What skills do you have? Well, we're gonna teach you how to do vital signs, height and weight, right? I will show you how to fill out an inventory list. Everything you need to know, we're gonna do those things. So that way, when you write your resume, when you go to a job interview, you can say, well, I can do admission, transfers, and discharge. I know how to do height and weight, vital sign. Let me tell you, you start saying all of these things, they have no choice but to give you that job. That job is yours, okay? With all the money that comes with it, okay? So let's talk about vital signs. Page 179. Explain the importance of monitoring vital signs, right? So we monitor, we report, we monitor, we document, we report vital signs. Vital signs are important. They show how well the vital organs of the body, such as the heart, the lungs, are working. So the vital sign consists of temperature, blood pressure, pulse, and respiration. Okay? Temperature, blood pressure, pulse rate. Pulse is how many heartbeat per minute. You're gonna know how to do that, how to check that. And the respiration is how many breaths the patient takes every minute. Okay. Now, sometimes when the patient is not doing good, vital signs will be affected, meaning that the vital sign is not going to be the same. Okay. So you need to know when to just document and go on and do your job, and when to report the vital signs. Okay, I see some people still coming in. That's very good. Text your friends, please, and ask them to join into this Zoom so they can, so they don't miss this. Okay, so at the bottom of page 179, temperature. So we can check the temperature by mouth, but in the rectum, that means the anus, right? Armpit, underneath the arm, axillary, tympanic, in the ear, temporal, that's the forehead. So you have oral, rectal, axillary under your armpit, right? Tympanic and temporal. Now, in the nursing home, for the most part, we check temperature using Fahrenheit. In the hospital, for the most part, especially if you're dealing with babies, we check the temperatures using Celsius. Okay? So when you guys get a chance, pull out your cell phone, take a picture of this range. Okay? So when I look at the range by mouth, if I have a temperature that's 98.6, I know that temperature is normal. If I have a temperature that is 100.8, I know that temperature is too high. I need to report that. So basically, when it comes to vital signs, the nursing assistant needs to know when the temperature is too low or too high, pulse is too low or that's too high. If the old temperature is 34.2, that's too low. So we need to know, and we need to report that. We need to know what's good, what's normal, and what's not normal. Okay? Same thing with the pulse. Normal pulse rate between 60 and 100, right? Beat per minute. If you check the pulse, right? If you check the pulse and you have a pulse of 100 116, that's too high. If the pulse is 70, that's very good because it's between 60 and 100. If the pulse is 50, that's too low. Respiration, normal respiration rate between 12 and 20. If I have a respiration of 16, that's very good. But if the respiration is 26, that's too high. If the respiration is only 6, that's too low. So the CNA needs to know that. Same thing with the blood pressure, but we will talk more about that later on. Okay? Now, page 180, page 180, okay? Page 180. Temperature, body temperature is normally close to 98.6 Fahrenheit or 37 degrees Celsius. Body temperature measure is a balance between the heat created by the body and the heat lost to the environment. Okay, so when we talk about temperature, we're talking about everything that's going on in the body to create heat. Your heart is working, your lungs are working, kidneys, lungs, your intestine, everything is working and creating heat. So when we check the vital signs, we are checking the heat produced by the body. Okay, now when your patient is sick, if your patient is on medication, if your patient has an infection, if your patient was exercising, vital signs will be elevated. It will not be the same. Okay, now so illness, stress, environment, exercise, circadian rhythm. Circadian rhythm is the sleep-wake cycle. During the day, your body temperature is up here. During the night, your body temperature drops a little bit. And that's why at night, even when it's not too cold, you throw on the cover because your body temperature drops a little bit. Okay? Now, we check the temperature in different places. We said that earlier. Mouth, oral, right? Temporal, right? Tympanic, okay? Where else? Axillary and rectal in the bum, in your rectum, okay? Now, we use a special instrument to check the temperature. Okay, what is that special instrument? We call it the thermometer. Okay, that special instrument is called a thermometer, right? Now, we have different types of thermometers. We have digital, right? You put a little battery in it and it works, right? With the digital, we have electronic thermometer, and we can use those thermometers to check temperatures by mouth and under the armpit. Okay, so for oral and for axillary. All right, let me mute some more people. All right, do not allow participant to unmute. All right, mute. There you go. All right, sorry guys, but we gotta stay focused and get this thing covered. Okay, so we have digital, electronic, tympanic. Okay, tympanic thermometer is a thermometer for the tympanic site in the ear. Temporal thermometer is the type of thermometer you roll on the forehead, right? And the difference between the rectal thermometer and oral thermometer is red. Okay, now page 181. All right, page 181. Now, when we talk about checking the temperature, okay, when we talk about checking the temperature, there are times, just like you need to know when you should not check the temperature, you also need to know, just like you need to know what's good, what's normal and what's not normal, you also need to know where you can check the temperature and where you cannot check the temperature. Okay, so for example, can you page 181, and a nursing assistant should not measure an oral temperature on a person who is unconscious. You see that at the bottom of page 181. Has recently had facial or oral surgery, younger than 5 years old, confused, disoriented, heavily sedated, etc. Right? So we need to know that there's a point where you gotta put a stop to it and say, okay, I can't check this temperature because here's what's going on with the patient. Okay, so the nursing assistant needs to use good judgment. Okay, you need to use good judgment. All right, so how do we measure and record oral temperature? Page 181. Okay, do not take oral temperature if the resident was smoking, if the resident was drinking something hot or something cold. Okay, you are exercising, because it makes the body hotter, right? The coffee will make the mouth hot. The ice cream will make the mouth cold. So if you check the temperature right after your patient had ice cream, the thermometer gets confused. Okay? If you check the temperature after your patient had coffee, the thermometer is going to say this person has a fever because the mouth is hot. So you have to wait 10 to 20 minutes before you can check that temperature. Number 1, 2, 3, 4, and 5, all of them are beginning procedure steps. Step 1, 2, 3, 4, and 5. Step 6, digital thermometer, you have to put a disposable sheath, a disposable cover, a little plastic cover on top of it, okay? For the digital thermometer, same thing for the electronic and for the mercury-free thermometer, okay? Now, for the mercury-free thermometer, you definitely need to shake that thermometer before you before you use it, so you can push the mercury down. All right, now go to page 182. Page 182. Okay, you could see the hand with the blue glove shaking the thermometer down to push the mercury to the end of the thermometer. Okay, digital thermometer or electronic thermometer, you put inside the patient's mouth. You ask the patient to raise their tongue, and then the thermometer will go. Let me just use this pencil. Hopefully I don't catch germs. So the thermometer probe will go way deep, like over here. And then you ask the patient to rest their tongue on it, okay, and keep their mouth closed. And the thermometer is in there, okay. The digital thermometer will beep. The electronic thermometer will beep. The mercury-free thermometer will not beep, so you gotta hold it for 5 minutes at least. Should hold it, but you gotta remember to tell the patient not to bite the probe of the thermometer. Okay, so step number 9, remove the probe from the patient's mouth. Get rid of the plastic cover and then clean it up, right? Wipe it with alcohol and put it away, right? And then you do your hand hygiene and your finishing steps. All right, page 183, measuring rectal temperature. The nursing assistant must always explain what she will do before starting to measure the rectal temperature. You need to get the patient's cooperation. The patient needs to agree with you before you pull down their pants to try and check their rectal temperature. You got to know that. Okay? Step 1, 2, 3, 4, and 5. All of that are your beginning procedure steps on page 183. Have the resident to a left side lying position. So you're gonna put the patient in the Sims position. Sims position is the left side with the right leg, with the left leg straight down and the right leg upper bent at a 90-degree angle to the body. Okay? Next, you unfold the linen to expose only the rectal area. Put on gloves. Now, for a digital and electronic thermometer, you press the on button and then you wait for the machine to give you the signal to start. You put the plastic cover on the probe, right? For the mercury-free thermometer, yes, you shake it down. You put the cover on it, right? And then after the plastic cover on the probe, you have to put a little bit of lubricant to make it easy to slide into the anus. With one hand, you separate the anus, you separate the buttocks, right? And you insert the thermometer into the rectum 1/2 inch to 1 inch, 0.5 to 1 inch deep, and you hold it in place, okay? If you meet resistance, don't force it. Go to page 184, okay? Go to page 184. 184, replace on the top here, let's see here, when you're done, cover the patient back up, right? For the thermometer, now hold on a second. Well, step 11, you insert the thermometer, the probe in the rectum, okay? And then 12, you cover the patient back up, right? While you're holding the thermometer in place. That gives the patient a little bit of dignity, okay? The mercury-free thermometer, you hold it in place for 3 minutes. And then step 14, gently remove the thermometer. Read the thermometer at eye level for oral, at eye level as you would for oral temperature. So you would raise it up to do the reading, okay? Step 16, clean your thermometers, right? Remove your gloves, assist the resident to a safe position, and 19 to the rest are your finishing steps, okay? Finishing steps. Now, when I mention finishing steps and beginning steps, if you don't know what they are, you need to go back to chapter 1, okay? All right. Or you can just go back and watch the video. So pretty soon I'm going to share my screen with you, and then you guys can let me just do that now. Oh, no, can't do that yet. I got some stuff I need to close on that screen here. Okay, can't do it yet. Okay. Oh, nice. Measuring a temp are your beginning procedure steps. Number 6, put a disposable sheath over the earpiece of the thermometer. So you need a tympanic thermometer, right? Before you can to check the tympanic temperature. Put the resident head so that the ear is in front of you. Straighten the ear canal by gently pulling up, okay, back and up, okay, and insert the thermometer probe into the ear canal. But there's also a cover on the probe, right? Okay. Now, the machine, you're gonna hold it until the machine either blinks or beeps. Okay. Read the thermometer once it beeps. Take it out. Read the temperature. do the temperature reading. Number 10, clean up your thermometer. And number 11 through 15, your finishing steps. Okay? Your finishing steps. Hand washing, record temperature, date, time, and method. Yes, anytime you check the temperature, you got to put in your note where the temperature comes from. O for oral, okay? R for rectal, all right? T for tympanic, right? So you got to let the nurse know, okay? You got to put it in your notes where the temperature comes from, okay? Measuring the axillary temperature, again, step 1, 2, 3, 4, 5, and 6. That's your beginning procedure step. 6, you put on your glove. We're on page 185. Page 185. You put on your gloves. Remove the arm from the sleeve. So just one arm from the sleeve. Expose the axilla. Expose the armpit. Right? And your digital electronic thermometer and your mercury, you will remove the probe from the base, from the thermometer, and basically you will for the mercury free, again, you have to shake the thermometer down to get the mercury toward the end of to move down to the end, to the tip of the thermometer. Okay. Number 9, position the thermometer bulb end for the mercury free in the center of the armpit. Okay, so whether it's your digital mercury or electronic thermometer, the tip of the thermometer goes inside here, and you put it on the side like this, and you ask the patient to hold down their arms. So you do direct skin contact. So you would open the shirt, and then you would go inside here, right? Let me see here. You would go inside here, inside the shirt, and then you see that's the thermometer going right here to the center of the armpit here, and then you put it in the armpit, and then boom, direct skin contact. You hold it in place, and the mercury, you have to hold it for about 10 minutes, 8 to 10 minutes, but the digital and electronic thermometer, they will beep, okay, or blink to tell you that they are ready. Go to page 186. Page 186, flip the page. Okay, now you can see the thermometer. You can see a nice picture here of direct skin contact of the thermometer with the armpit, okay? And you hold it in place for 8 to 10 minutes, okay? Step 11, remove the thermometer, read the temperature for both electronic and digital, okay? For the mercury free, same thing. Wipe it up with a tissue from the stem to the bulb and remove the sheath, okay? Using a tissue, remove the sheath and replace the thermometer in the case. For both digital, we call all of that your finishing steps. Just when you document, make sure you report the site where you check the temperature. Pulse is the number of heartbeat per minute. The heartbeat 60 to 100 times in 1 minute, in 60 seconds. Okay, so the heartbeat is felt at certain pulse point in the body, okay, which represent waves of blood moving through the arteries as a result of the heart pumping. So when you check the pulse, you're actually feeling the wave of blood just like the waves of the ocean. The most common place where we check the pulse is the radius. fingers, okay? So that's why we call it the radial pulse, okay? Now, if you look at your hand here, you'll follow your thumb, and then boom, it'll be right here in your thumb, and then you can support it with 2 fingers. Never check pulse with your thumb, but check it with these 2 fingers, make them equal, and bring it down here and look for the pulse. All right, guys, keep sending message to your friends and ask them to join. I like that because they need to catch this information. Okay, so you check the pulse for 60 seconds, for a full minute. Okay, now on page 186 you can see temporal pulse. If you put 2 fingers here, right, if you look around your temporal artery here, I can feel the beating. If you put 2 fingers here, I can feel the beating. That's my carotid pulse, right? Right here over the heart on the left side. If you put it right under the breast here, all right, with a stethoscope, you will hear the apical pulse. The brachial pulse is right here on the inside, and the radial pulse is right around the wrist. You check it with these 2 fingers. Okay, you got femoral, popliteal, and pedal pulses. All right, it's important to experiment and find all of these pulses. Okay, I'd like for you to be able to find it. Why? Because if you work in a in a hospital, right? On page 186. If you work in the hospital and your patient had leg surgery, okay, or either thigh surgery, leg surgery, you should be able to check for pedal pulse, okay? Because the nursing assistant needs to be able to notice the pulse, the presence, and the quantity of the pulse per minute, and the quality of the pulse. Okay? So is it fast? Is it hard? Is it weak? Is it bounding? Is it weak? And how many beat it is? Right? So if you put 2 fingers here, maybe I'm going into nursing territory, but you guys are future nurses. So don't mess around, right? If you put 2 fingers here, right? And you feel the carotid pulse. We call this the carotid pulse, right? When I feel it to see if it's regular, okay? And regular means regular beat, regular rhythm. Boom, 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 boom. That's regular, okay? I feel to see if it's weak or strong, because sometimes the pulse goes. Oh, a strong pulse goes, and you can feel that with your fingers, okay? And you count how many pulse it is per minute. And if you don't feel the pulse, if it's absent, you need to tell. Usually when the pulse is absent, you can see changing, becoming darker, but let's not go there, okay? All right, let's go to page 187. Page 187. So the normal pulse rate for adult is 60 to 100 beat per minute. Smaller children have faster pulse in the range of 100 to 120. Newborn have higher pulse between 120 and 180. So the younger the person, the faster the pulse, right? And many things can affect the pulse, like fear, anger, anxiety, heat, infection, illness, medication, pain, etc. So that's good information to know. Respiration, page 187. Respiration is the process of inhaling air into the lungs, okay? When you inhale, You bring your breath in, you suck it in. Okay, we call that inspiration. When you exhale or you push it out, we call it expiration. Okay, we call it expiration. Okay, so each respiration consists of inspiration plus expiration. Okay, so the chest rises during inspiration and falls during expiration. When you breathe in, chest goes up. In, when you breathe out, chest goes down. Okay, now as I'm doing this lecture, every time you see the the blue circle with the white arrow, that means there's a video for that. Okay, and I'm gonna share my screen to show you guys the video later on. Okay. All right, so respiration, the normal respiration rate for adult is 12 to 20. For infant is 30 to 40. Okay, for children and infants may have faster respiration rate. Okay, again, sickness, fear, anxiety, medication can affect the respiration rate. Okay, now counting the respiration, counting the and recording radial pulse, and counting and recording respiration, bottom of page 187. That's a very important skill right there. Why? Because that's a potential state exam question. That's a potential state exam request to perform this skill. Step 1, 2, 3, 4, and that's your beginning procedure steps. Okay, step 5 on page 187, place the tip of two index finger, okay, on the radial pulse. Now you got to take your time to go look for the pulse. It's right here by your thumb. You put two fingers here. Make sure you look for it, you find it, and you can feel the beating of the pulse under the wave of the pulse under your fingertip. And when you feel it, after you feel it, you can begin to count what you are feeling, okay, which is the waves, each wave per minute. Okay, each wave in one, so you're going to be able to count how many waves, how many beat in that minute. Okay, number one, page 187, number 6, count the beating for 1 full minute for 60 seconds. Keep the finger, now step 7, keep the finger on the resident's wrist and now begin to count the respiration for 1 full minute. So on your state exam, you say to the patient, you do your beginning steps, right? Beginning steps, don't forget them. And then you start checking the pulse. 1 full minute, you're checking the radial pulse. Now, if the radial pulse is, say, 74, for example, 74 beats per minute, right? After I'm done checking the radial pulse for 1 minute, I keep my fingers there as if I'm checking the pulse, but not for 1, up and down, 2, 3, 4, 5. You see, in, out, that's 1. Okay. And the normal rate for the adult is 12 to 20. If you get more, that means you were counting it wrong. Counting it wrong, if you're counting it wrong, you can go 1, 2, 3, 4, 5, 6. So if you're counting inspiration and expiration as 1, that's as separate, that's wrong. So 1 inspiration, 1 breath in, 1 plus 1 expiration, 1 breath out equals 1 breath. So inspiration plus expiration equals 1 breath. Okay? So when you finish, you remove your fingers. Now, at the end of 2 minutes, you got 1 minute for the pulse, 1 minute for respiration. Now, let me add this. On your state exam, on the state exam, you check pulse and respiration on the left hand, the nurse is going to check pulse and respiration on the right hand. So that means you can't lie. And if you check the pulse and it's way higher than what the nurse checked, then hey, you're wrong. Okay? You're gonna lose that point. So make sure you practice and you know how to check and find the pulse and count that pulse for 1 full minute. Okay? For 1 full minute. Okay? Step 8, 9, okay? Finishing steps. Now for step 9, record the pulse, date, time, method. So when you record the pulse, you need and your job, you need to let the nurse know that the pulse was radial or tympanic or axillary, radial, brachial, all right, or wherever you got the pulse from. All right. The most common place to check the pulse, ladies and gentlemen, is the radial pulse for nursing assistant. Go to page 188. Let's talk a little bit about blood pressure. Blood pressure is an important indicator of health. The measure shows how well the heart is working. Blood pressure is measured in millimeter mercury, mmHg. It is recorded as a fraction, for example, 110 over 70. So that's how you read it. 110 over 70. Okay, so we have systolic numbers and we have diastolic numbers. So in the systolic phase, which is the top number of the reading, the heart is at work. It contracts, it pushes blood out. So when the heart contracts, it pushes blood out and a wave of blood goes rushing out. Okay, it rushes blood out from the left ventricle. Okay, and the reading shows the pressure on the wall of the arteries as the blood is pumped through the body. The second measurement, right? Are you looking at the book? The second measurement reflects the diastolic phase, okay, which is the bottom number of the reading. Okay, now this is when the heart relaxes. The diastolic measurement is when the heart relaxes and blood comes back into the heart. It shows the pressure in the arteries when the heart is at rest. The normal range for systolic measurement is 80. The normal range for systolic is 120, and the normal range for diastolic, okay, for diastolic is 80. All right. So basically, we use an instrument. The instrument we use to check the blood pressure is called a sphygmomanometer. CNA or a nurse, even for a doctor to learn. The only way you can get this right is by doing what we call repetition, which means you buy a stethoscope and a blood pressure cuff for $20 on Amazon, and then you practice. You practice. You watch the video, you practice and watch the video until you get it right. Because even after I show it to you in the class, believe me, that's just the beginning. You know, so I don't like to use the digital blood pressure machine, the electronic blood pressure machine, because I want to keep the skill. I want to remember the skill. Measuring and recording blood pressure. Step 1, 2, 3, 4. We're looking at beginning procedure steps. right? Step 5, before using the stethoscope, wipe the diaphragm and the earpiece with alcohol wipes. You're gonna see all of that on the video. Okay, ask the resident to roll up their sleeve. Number 7, position the arm with the palm up. Okay. Number number 8, with the valve open and squeeze. With the valve open, squeeze the cuff. Make sure it's completely deflated. Place the blood pressure cuff snugly on the resident's upper arm. Okay. Ask the resident to remain still and quiet. You gotta ask the resident to not speak. Okay, as you check this, the blood pressure. Locate the brachial pulse with your fingertip. Place the earpiece of the stethoscope in your ear. Place the diaphragm of the stethoscope over the brachial artery. Close the valve clockwise until it stops. Right? Go on to the next page. All right. Page number 15, inflate the cuff to between 60 and 100 millimeter mercury. If a beat is heard immediately upon cuff deflation, completely deflate the cuff and inflate and reinflate the cuff to 200. So at first you push it to 180, and then if that doesn't work, then you go up to 200. Okay. Number 16, open the valve slightly with your thumb and index finger, then deflate slowly. 17, watch, we're on page 190. Go to page 190, page 190. Okay. Watch the gauge, listen for the sound. Remember the reading at the first pulse, when at which the first pulse is heard. That's your systolic. Okay, continue listening for a change and muffling of the pulse. All right, and then open for a change to the point at which the sound disappears. Listen, guys, I can read all of this to you, but the video shows the actual blood pressure being taken. Okay, so after this lecture tonight, when you come back to this again tomorrow, okay, what I need you to do is, with the book open in front of you and your cell phone right there, you watch the video on blood pressure. You watch the video on temperature, on pulse, respiration, okay? We have multiple resources, okay? All right. Let's go into measuring the blood pressure electronically. Now, this one is very simple, all right? Step 1, 2, 3, 4, and 5, that's your beginning procedure steps. So the same thing you did for the blood pressure for the manual is the same thing you will do. Wrap the cuff around the arm, okay, on bare skin, okay? Put it on bare skin, and then, hey, just press the button. Once you have the proper position, you just press the button, and then next thing you know, you have all right. Okay, very good. All right, you press the button, and then the machine does the inflate and the deflate, and next thing you know, it reads the number. Okay. If you use the electronic blood pressure machine, you will forget how to check the blood pressure manually. All right. Okay, now page 191. Let's talk about other skills, okay? After your patient has surgery, they lay in bed for a long time, okay? Now, it depends on the extent of the surgery. So, if your patient is in bed, we need to check the oxygen level, okay? Meaning how much oxygen is going into the body as the patients breathe. Because we want to make sure that this patient is not going to experience any type of respiratory distress. Okay, we need to make sure this patient is not going to have that. So there's a little instrument we use called a pulse oximeter. Okay, pulse oximeter is a device, page 191, that uses a light to determine the amount of oxygen in the blood. A pulse oximeter also measures the pulse rate. Okay, and it does that in a few seconds, right? The pulse oximeter may be used when residents have had surgery or on oxygen or intensive care or have cardiac or respiratory problem. All right? So we check vital sign, temperature, blood pressure, pulse, respiration. We also check oxygen level. Okay? Now, pain management. Okay, now they often say vital sign is blood pressure, temperature, pulse, respiration, and pain. So we call a pain the fifth, the number 5 of vital signs, the fifth vital signs. Okay, pain is not considered a form of vital sign, but is very important to manage, to monitor and manage. Pain can be very uncomfortable, and it can greatly affect a resident's quality of life. Pain will reduce energy, will drain energy. Pain will reduce the hope, will make the patient feel that, okay, I want to die now. I'm done. Okay? A person in pain, I tell you, it's an awful thing. Pain is not a part of aging. Chronic pain can be led to withdrawal, depression, isolation. Okay? So, now, when your resident report pain, our job as nursing assistant is to dig for more information. Okay? Patient says, I have pain. Okay, great. Now, that is what we call subjective information. When the patient says, I have pain, that's subjective information. Objective information, can you show me where it is? Because I want to see it. Objective. If the patient is right here, I want to see if there's swelling. Objective information. I saw it. If there's redness, heat, bruising, etc. Right? So where is the pain? When did it start? How long does the pain last? How often does it occur? How severe is the pain? Can you describe the pain? Page 192. Go to page 192. Okay, page 192. What makes the pain better? What makes the pain worse? Can you rate the pain on a scale of 1 to 10? Okay. A lot of patients will not complain of pain even when they have pain. Why will they not do it? It is because these patients, they are afraid of pain medication. They don't want to get addicted. They don't want to be constipated. Yes, pain medication can lead to addiction. Yes, but it's not a funny thing. So patient may feel that even the pain medication will kill them, will cause death. All right. So a lot of time the patient will not report the pain. So the nursing assistant's job is to monitor, is to look at what's going on with the patient and report what's going on. Okay, so pain management. Before we go into pain management, go under and read, and let's read observe and report the pain. Observe and report. Okay, increased pulse, respiration, blood pressure. Why? Because pain will affect vital signs. Okay, sweating, nausea, vomiting, tightening of the jaw, squeezing the eyes shut, clenching the fist, frowning, grinding the teeth. So all of that can indicate that this patient is having pain. Okay, now Pain management. What can we do? Report complaint of pain. Gently reposition the patient in proper body alignment. Use pillow for support. Give back rub. Ask the resident if they would like to take a warm bath or shower. Help resident to the bathroom and or commode and offer bedpan or urinal. Encourage slow deep breathing. Calm quiet environment. Be patient, caring, gentle, responsive. Okay? How do we measure weight? How do we measure height and weight? Height and weight, they are not part of vital signs. They are part of regular care. Height checks less often than weight. We check weight more often because, weight change is a sign of illness. A resident must report any weight loss or weight gain. Okay? So, measuring and recording weight on an ambulatory patient. Step 1, 2, 3, 4. That's part of your beginning procedure steps. Step 5, make sure resident is wearing non-skid shoes or non-skid footwear. Start the scale at 0 before weighing the resident. Help the resident to step onto the scale to the center. We are on page 193. Page 193. Step number 8, determine the resident's weight. Balance the scale by making the balance bar level. So checking weight on the scale is something we will be doing in class. All right? Okay. What else? Okay. Help the resident to safely step off the scale. Okay. Let's see. Going back to 8, determine the resident's weight. Balance the scale by making the balance bar level. Move the small and the large weight indicator. Let's see. Until the bar balances. All right. So now the video speaks louder, speaks more volume than the reading. Okay. Step 11, 10, 11, 12, and 13. That's your finishing steps and recording the weight in pound or kilograms. Okay. We're almost there, guys. Hang in there with me. All right. Hang in there. All right. I know you guys are sleepy. Hang in there. All right. Now there's wheelchair scale. For the wheelchair scale, what we would do is we would put the patient on the wheelchair. All right, and then wheel the patient on the scale. Right. Take the weight of patient and the scale, and then minus and then we put the patient back to bed, and then we check the weight of the scale. Again, to check the patient's weight on the scale, we would sit the patient in the wheelchair, push the wheelchair to the wheelchair scale. We take the weight. For example, let's just say the scale says weight is 240. So we write down 240. Once we take the patient back with the patient and the wheelchair, and I have the wheelchair by itself weighing 40, the total weight is 200, right? All right. Now, let's move on to height, okay? The same scale that measures the weight can also measure the height. And I will do the demonstration in class as well. You have to have the patient stand with their back against the scale, right? Page 194, step 1, 2, 3, 4, 5, that's your beginning procedure steps. Step 6, help the patient to step onto the scale, facing away from the scale. Ask the resident to stand straight. Pull up the measuring rod to the back from the back. Gently lower the rod until it reaches it rests flat on the resident's head. Determine the height by doing the reading. I will show you how we do that. Okay, help the resident to step off the scale 11, 12, 13, 14. That would be your finishing steps. Again, guys, don't be upset. Calm down. Once you watch the video, it will make more sense. Okay? All right, Carla? All right, so relax. Don't be upset. Once you all this reading can make you go "Wah!" Right? But you watch the video, you just sit back and you're like, oh, so that's what this is. Very simple. Okay? Very simple. All right? Page 195. If your patient cannot stand up to check the weight, the height, you want to put the patient bed flat. Put the patient in a supine position, laying flat on their back. And then you get a measuring tape. You measure from the heel, okay? You measure the length of the patient from the heel, all right, to the head, okay? You measure it that way, and there you have it. How many centimeters or inches that it is. Restraint is can be physical or chemical restraint. They're physical or chemical way to stop or to restrict movement or behavior. When our patient is confused, when we have patient with mental illness that are agitated, the doctor will oftentimes give order for a restraint. The order for the restraint can be physical. Physical restraint can be, a belt restraint, vest restraint, wrist or ankle restraint, or mitten restraint. Okay? Chemical restraint, page 185, are medication used to control a person's mood or behavior. Okay? So chemical restraint can be medication, can be the pills. Okay? So, most places don't like to use restraints. Go to page 196. Page 196. If one side well is up, we call that, if one side well is up, that's not a restraint. But if both side rails are up on the bed, we call that restraint. Okay? Same thing if you have the tray that's attached to, the tray table that's attached to the jerry chair. Okay? Now, they used to use restraint a lot, but these days we don't like to use restraint because of the risk that comes with using the restraint. What risk comes with using a restraint? Page 196, pressure or injuries, right? Pneumonia, risk of choking or suffocation, reduced blood circulation, stress on the heart, blood clots, incontinence, constipation, the risk death. Okay, so therefore restraints can only be used with a doctor's order. Only a doctor can order a restraint to be used. That's why most places they would use what we call restraint alternative. Okay, restraints use is significant, has this significantly decreased in facilities. State and federal agency encourage facilities to step away to create restraint free environment. Restraint free care means that restraints are not kept and used for any reason. Okay, so creative idea that helps avoid the need for restraints are used instead. All right, so for example, so we call that restraint alternative. Okay, so for example, page 197, make sure the call lights are within reach, respond to call light promptly, improve safety measures, ambulate the resident if they are restless, provide activity, encourage activity and independence, provide frequent help with elimination, offer food and drink, etc. Okay, so the list of things that we can use, we can do as restraint alternatives is right there. Okay, so restraint alternatives means instead of tying the patient up, instead of giving the patient pills, all right, we would basically do these things. All right, now so if you're working in a facility that use restraint, okay, go to page 197. Okay, the restraint, okay, you must check the patient every 15 minutes. The restraint must be released every 2 hours, and when given care, right? If you helping the resident with elimination, you got to remove the restraint. Offering food and fluid, you got to remove the restraint. Vital signs, you have to remove the restraint. If you're checking the body, the skin or any body parts, you must check. You must remove the restraint to do your job. Okay, we're going to talk a little bit about fluid balance. Okay, fluid balance basically means, you know, a normal balance between how much fluid is going into the body and how much fluid is coming out of the body. The fluid a person consumes is called intake or input, but it's mostly intake. The fluid that comes out from urine, for example, or it could be diarrhea, okay, we call it output. So basically we measure intake and output. How much fluid this patient was drinking during the shift, and output, how much fluid came out as we measure the urine. Fluid balance is maintaining equal intake and output, okay, and taking in and eliminating equal amount of fluid. Okay, now when we report intake, we report it not in ounces, but we report it in ml, in cubic centimeters. Okay, so to convert ounces to milliliters, okay, so cubic centimeters and milliliters are the same thing. Okay, so 1 ounce equals 30 ml. Okay, now remember the cup is ounces, comes in ounces, but when we report in ml. We don't report or document in ml. So 1 ounce is 30, 2 ounces, that's 60 ml, right? 3 ounces, that's 90 ml. You can see the number on page. Multiply the number of ounces by 30. To convert ounces to ml, you multiply by 30. Okay? Okay. Now, page 198, you can see how we're going to document intake and output for every shift. Okay? So, documenting is part of your job. Documenting means writing it down. How many cups of water, of juice? I see somebody drinking water from a bottle, right? So that's intake, Carla. Congratulations. Pretty soon you have to do output. Go to the bathroom and let it out. All right? So we document every shift. And the person that works the last shift of the day will add it all up. Okay? We'll do the total. All right? Okay. Now we're going to move a little bit faster. Collecting urine collecting specimen. Let's say it may need to collect a specimen from a resident. Specimen is a sample that is used for analysis in order to make to try and make a diagnosis. Okay, so there's urine specimen, feces specimen, and sputum specimen. Urine specimen is a little bit of urine that we collect and we put it in a urine cup, in a specimen cup. We close it, we put a label on it and send it to a lab. A routine urine specimen, we have different types. A routine urine specimen is collected anytime the patient avoids or the patient urinates. All right. So sometimes we would put what we call a hat, the white one on page 199. We put the hat. We sit it on the toilet, and we have the patient urinate on there. Okay. Now again, you may go on YouTube to watch the videos on how to collect those different types of urine. There's routine urine specimen, there's clean catch, and the clean catch urine specimen, and there's also clean catch, sometimes we call it midstream urine specimen. All right. Routine is anytime, but before you do you collect the urine specimen, make sure you perform perineal care or teach the patient to wipe themselves from front to back with a towelette, okay, if it's male or female, okay, before you collect the specimen. For clean catch, or what we call midstream specimen, it does not include the first or the last drop. So during this procedure, after you perform your beginning procedure steps, you let the patient begin to urinate in the toilet, and then as they urinate, before they finish, you put the cup under the stream, you collect it midstream. Before they finish and the last drop of urine comes out, you remove it and let them finish in the bathroom. Okay? All right. Page 102. Go to page 202, sorry. Page 202, right? Hang in there, Carla. I'm almost done. Don't fall asleep, mama. All right, Colleen, you too. All right, I'm watching you, Bernadette. Jolene, stay up with me. All right, collecting urine, collecting a stool specimen. So basically, you will get that specimen cup, and then you get either a spoon or a clean spoon or fork or something to scoop it up and put it in the specimen cup. Now, why do we need a urine specimen? If you notice anything abnormal with the urine, right? What's the no? Right? No strong odor, right? Easy to come out, no problem, right? And the patient will produce 50 ml of urine per hour. So at the end of your shift, 50 multiplies by 8 hours, that should give you about 400 ml of urine. Okay? Now, why should we collect urine? Why should we get a urine specimen? If you notice that the urine is red, it could be an infection, it could be bleeding. So the only way we're going to do that is a specimen sent to the lab. If the urine is cloudy and odor is strong and powerful, that's an infection. There could be problem. If the urine looks like frank blood, we could be dealing with bleeding or cancer or prostate problem. Anything is possible. So, in healthcare, we don't guess. We send the specimen to the lab to determine the true nature, the true cause of that problem, and then the doctor can prescribe the type of medication or treatment that this patient needs. Okay? All right. So, same thing for the stool specimen. Why should we collect a stool specimen? Well, before you flush your doo-doo, right, take a look at the doo-doo, right? So if the patient has a bowel movement, the patient doo-doo in the bedpan or doo-doo in the bathroom, if the dookie is red, patient could be bleeding. If it from the rectum, if it's black, they could be bleeding from the intestines, right? Or it could be cancer somewhere, right? If it's clear, if it's very loose, we're dealing with diarrhea. If it's very hard, we're dealing with constipation. If it's white, like clay color stool, we're dealing with gallbladder problem. So what you report as a nursing assistant tells the nurse here's what the problem can be. So therefore, to be completely sure, we sent a piece of the BM to the lab, okay? And they study it and analyze to find out what the problem is. Page 203, we often care for patients with urinary catheters. Okay, a lot of times your patient may have difficulty passing the urine. Okay, it could be because of bladder problem, it could be because of a number of problems, cancer or whatever. Okay, the catheter is a thin tube inserted into the body, and it is used to drain fluid, okay, or inject fluid in the body. However, the urinary catheter is it drains urine from the bladder. Okay. Now we have three types of catheters that we use, right? Straight catheter, that's a nursing procedure. You just need to know what a straight catheter is, but it's not your job to perform it. Straight catheter is a catheter that goes into the urinary meatus of the male and female. We keep pushing it until it goes into the bladder. Once the urine goes into the bladder, it drains the fluid, and then once the tube goes into the bladder, drains the fluid, we pull it out gently. Okay? Indwelling catheter, we put it in, we push it into the bladder, and we leave it in there. Okay? There's a little bulb at the end of it. The nurse knows how to inflate and deflate, okay? And whatnot. So you can see page 203, okay, the catheter, okay? Now, the condom catheter is basically like a condom that you put on a man's penis, okay? And basically, the catheter tube and bags are connected to it, okay? So, guidelines for the urinary catheter, okay? Hand washing, keep the genital area clean to prevent and is lower than the bladder. Otherwise, the urine will backflow into the bladder, causing infection. Okay, keep the drainage bag off the floor because bacteria will start growing and get into the bag, grow into the tube, and go all the way up into the bladder and cause infection. So the catheter bag should never touch the floor. Okay, make sure the catheter tubing is not twisted, is not kinked, okay, to prevent circulation, movement of the urine, okay? Observe and report blood in the urine. Catheter is not filled after several hours. That means this patient is retaining, and that's a problem. Okay, go to page 204. Page 204. Okay, page 204. We're almost there. All right. Providing catheter care. Now, catheter care is usually a state exam skill that people may have to perform. So circle this here, providing catheter care, okay? circle that and make sure you watch that video. We will practice it in the school, and then, I don't know what you're going to do to practice it more, but when you get into my lab on Monday, Tuesday, or Wednesday, do not waste time. Okay? As a matter of fact, what I want you to do is watch as many videos as you can and then come in and do the practice. Okay? Because chapter 6 has tons of videos. Chapter 7 has a lot of videos. Okay? So after this chapter 7 on this Zoom, when we get into the class, it's going to be practice, 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 practice. Okay? All right. It's going to be videos and practice. All right? So tell your friends. All right? Say to your friends, hey, listen, when we go to class on Monday, we're just going to do a lot of practice, man. Let's not mess around. Let's not play around. Okay? So providing catheter care, step 1, 2, 3, 4, 5, beginning procedure steps. Step 6, put the patient in a supine position. Step 7, remove and fold the sheet, the top sheet, to expose with a bath blanket, only to expose the genitals where the catheter is coming out. Test the water. You're gonna need some water. Temperature of the water is always 105. 9. Put on gloves. 10. Flex the knees and raise the buttocks. Right. To put bed protector under the patient. Okay. Place the towel under the catheter tubing before washing. So you place a towel under it to prevent it from touching the bed, to prevent it from getting dirty. Wet a washcloth in the basin. Now, this is something that you need to watch the video, and I will also do the demonstration. Okay? Right now, I don't have my own videos for demonstration, but they're coming up, because after I put all these lectures online, I don't need to keep talking in the classroom. We can just do more practice, and then you guys do more videos. You guys do more of the lectures at home. I gotta put this person. Sorry, can't talk right now. Somebody's gonna think I'm lying, but I really can't talk right now. Okay. So with the catheter care, of course you're wearing gloves. One hand, you pinch the tip of the catheter on page 205. Look at this. The tip of the catheter, where it comes out, with one stroke. One, you turn the side of the washcloth. Another stroke, you change its side again, one more stroke. That was your washing. You rinse it. To do the rinsing, you do the same thing. You pinch the catheter. So for catheter care, they're looking for you to pinch and clean. Pinch and clean. Okay? Drainage bag. Okay, to empty the drainage bag, you need to put gloves on. You need to get what we call the graduate. Okay, and you need to get paper towel, and you need to get a little bit 1 or 2 pieces of alcohol wipes. Your paper towel is on the floor. Your graduate sits on top of the paper towel. With gloves on, you open the valve, urine comes flowing out, and then you lock it, right? And then you break open your alcohol and you wipe the tubing where the urine comes out. All right, again, this is one video that you must watch. Okay? All right, and then you put it on a flat surface, right? You put it on a flat surface. All right, there's video on measuring the urine output. Once you get the graduate, you don't hold it up like this to read it. You put it on a flat surface, right? You put it on a flat surface, and then you will look. So this is a graduate. How do I have a graduate in my house? I don't know. But you put it on a flat surface, and you go down to read it at eye level. Again, we will do it in class, so don't worry. yourself. And when you finish, empty in the toilet or the bedside commode, rinse, dry, and put back in place where it belongs. If you don't clean your graduate on your state exam, you're not going to pass that test because that's an infection control. And since you're doing perineal care, you're doing catheter care or emptying a catheter bag, you had gloves on. What should you do after you have gloves on? Wash your hands, okay? And perform your finishing steps. If you go on to page 206, okay? Page 206, if your patient is on oxygen, make sure they keep the oxygen mask on or the nasal cannula on their face. Patient on oxygen, you need to remember that it's because they have breathing problems. So if these patients have difficulty breathing, you put the head of the bed up. You put them in a semi-sitting or in a sitting position. You make sure you put the nasal cannula on their nose or the mask around their faces, okay? Then we can also check the oxygen saturation with the pulse oximeter, right? Right there, you're a mini nurse, right? Remember, oxygen is combustible, it's flammable, so you must keep an eye on the patient to make sure that your patient is not smoking in a room where there's oxygen, because that will cause an explosion, okay? Flammable means easily ignited and capable of burning quickly. That's what's going on with oxygen. Page 207. Post a no smoking and oxygen in use sign. Never allow smoking around oxygen. Remove all the fire hazard. Do not burn candlelight matches. Do not use an extension cord with an oxygen concentration. Do not place electrical cord or oxygen tubing under rugs or furniture, etc. etc. Right? So, that's good information to know about oxygen, because, you know, that's part of the type of patients that you may have. Oxygen is considered a medication, okay? So when the doctor orders oxygen, we got to make sure that the patient keeps it on. You may go in the patient's room and see that the patient does not have the oxygen on and they're complaining of difficulty breathing. So what do? You suggest you help the patient put the oxygen back on. Okay? Page 207, intravenous therapy or IV therapy is the delivery of medication, nutrition, or fluid through a vein. Okay? Observe and reporting the tube. If the tube or the needle falls out, you don't push it back in. You just report that to the nurse. Tubing, this report to the nurse. Blood in the tubing, site is swollen, discolored, bag is broken. Any problem with the IV therapy, the IV treatment, you report to the nurse, okay? You don't try to fix the problem. If the machine is beeping, you don't press the silence button. The nurse needs to come and figure out why the machine is beeping. So you don't silence the machine. You don't turn it off. You don't turn it on. You don't check blood pressure on the IV, on the arm that has the IV. Okay? All right. Let's move on to page 208. Okay, let's move on to page 208. All right. Now, before I talk about page 208, going back to the IV. When dressing a patient with an IV bag, you need to disconnect, unhook the bag from the IV pole. You feed the bag through the sleeve of the shirt. And then you start with that arm. So you begin with the arm that has the IV, but you start with the IV bag first. Okay, you start with the IV bag. First, you go through that arm, and then you put you go through the sleeve, and then you put the arm there. So you start with the IV arm, and then you finish dressing with the non-IV arm. When undressing a patient with an IV, you start with the arm that does not have the IV to finish with the arm that does have the IV. Okay? All right. I just wanted to make sure I add this information. Plus, you can also watch that a video about that on YouTube. That's a great source of information right there. Okay. Now, page 208, the residence unit. Well, when we talk about the residence unit, we're talking about the patient's room. We need to keep it clean. We need to keep it at the temperature that the patient wants it to be. Okay. So your patient may have electric or manual bed, bedside stand, bedside table, urinal, bedpan, wash basin, emesis basin. There's a whole lot of things that the patient can have in their room. Our job is to keep things clean, organized, and reduce germs, reduce bacteria in the environment. Okay, teach the patient how to use the call light, answer call light. Teach the patient, how things work with the facility. Okay, page 209, guideline to the residence unit. Clean the overbed table after use. Keep the call light within reach. Put the call light in the strong arm or the strong hand, right? Keep equipment clean and in good condition. OBRA requires temperature out. This one here is very important for your state exam. Listen, anytime I say state exam, look at me. All right? Look at me. When I say state exam, you're like, huh? What did he say? State exam. OBRA requires that long-term care facilities have comfortable and safe environment for maintaining a temperature range of 71 to 81 degrees Fahrenheit. So grab your pen and mark that because you're going to need to know that information. That's a state exam question. Okay, remove meal tray after meals. All right, keep room clean from crumbs. Restock supplies. If trash needs to be emptied, do that. Okay, report signs of insect. Do not move residents belonging. Do not discard any personal items. Okay, observe and report. Now, if you're working the night shift, now, part of your job is to promote good sleep, so you can't be the one making noise to prevent the patient from, okay? You can't problems. Who knew chapter 7 was that damn long, right? But hey, we're almost there. Don't look so depressed, honey. You're almost a CNA too, so hang in there, all right? Lack of sleep can cause many problems, include decreased mental function, reduced reaction time, irritability, etc. Right? So, observe and report. Patient sleeping too much during the day, eating and drinking items that contain caffeine late during the day, wearing night clothes during the day, eating heavy meals at night, refusing to take medication ordered for sleep, etc. Right? So there's a lot of things at night. If your patient is not sleeping well, you need to report that. If your patient is sleeping too much during the day, we need to report that. Okay? So that leads us to bed making, page 210. Okay? Bed making is basically us making the bed. Now, you already been through making the occupied and the unoccupied bed. We taught you how to handle clean linen with clean hands. You wash your hands. You wash your hands. Guidelines, page 210. Right. Keep linen wrinkle free. Right. Wash your hands. Place clean linen on a clean surface within reach. such as a bed stand over bed table. Dawn gloves. Remember, dawn means to put on before removing dirty bed linens from the bed. Look for personal items such as dentures, hearing aid, jewelry. So before you undo the bed, make sure the patient does not have personal items on that bed, on those sheets, because if the denture ends up in the washing machine and goes into the dryer, those dentures are ruined, and the dentures sometimes can cost $5,000 or even $10,000 or $20,000. Okay, so eyeglasses can cost $500, $700. All right, if the and they are prescription. If they go in the washing machine, they're no good anymore. Okay, so you want to make sure you check for that. Okay, all right. If there's no patient in the bed, after you remove the dirt and then you clean the mattress, and then you make the unoccupied bed. Okay, to make the occupied bed means that there's a patient in that bed and the patient cannot get out of that bed. So on page 212, you will see the occupied bed. You turn the patient from one side to the next as you make these beds. Remember, whether you're making the occupied or the unoccupied bed, on page 211, you have to make the mitered corner that we sometimes call the hospital corner. If you're making unoccupied bed, you have to make the mitered corner. If you're making the occupied, you also have to make the mitered corner. Just make sure you collect your equipment in order. Okay, fitted sheet, bed protector, flat sheet, blanket, pillowcases. Right. If you're doing the occupied bed, you're gonna do bath blanket, fitted sheet, bed protector, flat sheet, fitted sheet, bed protector, flat sheet, etc. Right? We've been through that, and I know you guys took your notes. We went over how to change the pillowcases, all right, on the bed. Page 214, all right. A closed bed is a bed that doesn't have a patient in the room, so the sheet covers the pillow. The bed that does have a patient occupying the room, so the sheets are fan folded to the center or the foot of the bed, and the pillows are exposed. Okay. I think we're gonna stay here and leave these last two skills for you guys. Bandages. If you're applying bandages for a patient, it could be because they're having muscle pain or knee pain. Okay. So basically, with the bandage, make sure you don't put it too tight to restrict circulation, to block circulation, and you also check pulse at the extremity. So if you're putting a bandage right here, if you wrap a bandage right here, check the pulse. Okay. If you're putting a bandage on the leg, check the pedal pulse. So, and dressing, the only type of dressing that the nursing assistant would do is clean dressing. Okay, basically, a clean technique. Basically, that means the skin is intact. We just place a piece of gauze over a fragile but non-open skin. Okay. So that's it for tonight, guys. Thank you for following up with me. Thank you for keeping up. I know this is a big sacrifice for you. Please study, let me Let me acknowledge some of you guys that I see here. I see Carla De Silva still looking pretty. Colleen still looking gorgeous. Bernadette is hiding. Jeline is hiding. Big Papa is sitting there. You know. Hi, Jeline. Let me unmute people here. All right. I see here. Oh my goodness. Uh-huh. All right. Who else is here? People iPhone, Jean's iPhone, Naika, Jackie just entered the room. Aminta Midor, Elaine Gardner, Milan, Weekend Love, Sky, Samson. My students have weird name. Ismita, Pauline is here. Pauline, what are you doing here, Pauline? All right, but that's okay. Kimberline is here. Benita, Shakila, Abel, all of you guys, I appreciate you coming through. Let's see here. BV, LC, Tino, Widland, Beatrice. Oh my God. It's a lot of good people here. But anywho, we are done for tonight, guys. Thank you for joining in. We covered a lot of stuff today. We covered admission, transfer, discharge, vital sign, temperature, blood pressure, pulse, respiration. We cover measuring oxygen saturation, how to provide care and manage pain, right? We went over measuring urine output, intake and output, patients on urinary catheter. We did a lot of work, okay? And if you go on the HTTP Hartman site, you will see videos on everything we just did tonight. So tell all your friends, you know, study, 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 cover chapter 7 questions, because you have exam coming up on Monday. Okay? If not exam, at least we'll go over the homework for chapter 6 and and chapter 7, so that way we can move faster. The session is almost finished, guys, right? But I owe you a couple of weeks, so yes, that's the one I'm talking about, Carla. Make sure you do the one for chapter 7. So the way I cover the chapter, you don't have a lot of work to do as far as reading. Okay? So because basically I read most of this to you. Okay? So, and that you stayed up at night to follow along on a Zoom. Only Boston Healthcare Institute students are tough enough to do this. So big applause for you guys. Big applause. So if you have any questions, feel free to unmute yourself and ask before we say goodbye.
Hello.
Yep.
Will you be there Saturday, teacher, next Saturday?
Yes, this Saturday. Ooh, I can't move that. This Saturday.
As
Yes.
Christian.
Yes, I will be there.
Okay. At time. What time?
I'll be there all day.
Okay. Thank you.
All right, darling.
Have a good night.
You
Bye-bye.
too. Good night, Stacy. Anybody else? All right, then. If no one else wants to talk, I understand that. All right, guys. Have a great night. Thank you for joining me. This class was on YouTube, and you can also go back to it and watch it. Okay, guys? Thank you so much. Good night. Get some rest. All right, and I'll see you guys.
Good night, teacher.
Good night, Mama. You gotta unmute yourself. What'd you say, Carla?
Good night to everyone.
Oh, good night, sweetie.
Bye. Thank you.
My
Bye.
pleasure. Bye. Have a great night, guys.
Okay.
All right.
Bye. Bye,
Bye
teacher.
bye. All right. Okay, so how do we stop this? Okay. Oh, now I gotta find out how to stop this on YouTube.